Welcome back, team. So I've got another epidermal inclusion cyst for you, one of my favourite skin lesions to do. Probably one of the best pimple poppers that we'll see, at least in the foot. So this is from, looks like Weir and St Hilaire. Sorry guys if I've pronounced that wrong. Nice little online web article that you did, updated 18 months ago, so on epidermal inclusion cysts, and it says that they are the most common cutaneous cysts, and I've certainly seen a few. Lots of synonyms for them exist, including epidermoid cyst. I remember a couple of years ago trying to work out the difference between an epidermal and an epidermoid cyst, and of course different references said different things. Efundibular inclusion cyst, keratin cyst, and you'll sometimes hear them referred to as sebaceous cysts as well. And in fact, it's the only thing that they're really not. They're not filled with sebum. They don't come off the pilosebaceous unit. Sebaceous is true, very rare. In fact, I don't think I've ever seen one. So really like that little article by Weir, and I'm going to try that again. St Hilaire. It's just a very nice overview. But I've got a case report for you at the end that I'll highlight if you want to read more. So this particular patient, delightful lady, had come through with a soft tissue mass sub right first MTPJ. We scanned it, as I always do with my lumps and bumps. We want to make sure that it's entirely benign before we start taking the knife, fork and spoon to it. So they see on the T1 you've got cystic changes sub epidermis underneath the first metatarsal hair. There's T1 and there's T2. Fat suppressed. So you can see that's quite a fatty tissue there. So of course we go to the scan, and the scan says there is a thick-walled fluid signal, superficial subcutaneous lesion plantar to the hallux MTPJ, large, measures 3 by 3.5 by 1, has a tongue extending into the first intermetatarsal interspace, so it did go across a little ways. Internal low signal, so very much radiology speak. What I'm looking for is the bit right at the end, no sinister features, which means I don't need to send it off to my local sarcoma unit. I don't need to worry about this being anything that I can't take out. I only want to be taking out benign lesions on my TOD. Anything that's a bit cheeky needs to be done as part of a multidisciplinary team. But in conclusion, large complex cyst planted to the hallux, which may represent a complex adventitial bursa, but also a differential would include an inclusion or sebaceous cyst. So my local radiologists are fabulous, but even they've said sebaceous cyst. But a sebaceous cyst you're going to get off the pilosebaceous unit, off a hair follicle. Well, there ain't no hair follicles on the plantar surface of the foot unless there's been a skin graft taken from the thigh, which I've seen once or twice. So etiology, again, this is from the article by Weir and St Hilaire. Primary epidermal cysts arise directly from the infundibulum of the hair follicle, and that's the cavity or the fold. And you'll get a plugging of the follicular orifice, which allows for cyst formation. I've certainly seen a few of those on the scalp. Secondary epidermoid cysts arise. Really, it's an implantation. So inclusion cyst, as in you've got this effectively this sample of live skin that's been pushed through the dermoepidermal junction deep to the dermis. And then, very much like my career, it's got nowhere to go. It carries on shedding, but it can't shed because it's sub-skin. So let's just quickly look at the hair follicle. Do you know what? You really can't beat Wikipedia if you want to just have a little noddy look at things. I know it's not exactly high science, and my dissertation supervisor would have had me for mincemeat if I'd had Wikipedia as a reference. However, it's a good place to start. So if you look in detail at the hair follicle, so really, let's see if I can find a mouse. Oh, there you go. So really, this kind of this folding of the hair follicle, which is the infundibulum, as opposed to there's your pilosebaceous unit, which is where you're going to get your true sebaceous cyst, but I've never not seen one. So infundibulum, I hope I'm saying that right, a funnel-shaped cavity or structure. And that lining of the hair follicle will still want to try and shed and produce skin and desquamate. So here's our patient. This is in theatre. This was last week. Excuse a little bit of the strobing from the theatre lights, but you can see quite the size of lesion. Sub right first MTPJ. This is us prepping, and I've got a fabulous team. So I've got Donna and Karen. They are delightful, efficient, completely nuts, and politely laugh at nearly all my jokes. So we've done a medial incision. I've tried to come fairly low on the lesion. I'm taking a weather eye to avoid, if I can, the vascular and nervous structures, and so through skin and then deep dissection, and I'm going in with blunt dissection. You can see, let's go back to our mouse again. So really, here's your lesion here, and I'm just trying to get underneath it with the scissors and blunt dissect. So spread, cut, as my old tutor always used to say to me. Spread with the scissors, spread with the scissors, and then cut. Once you know you're not going to cut through anything that you shouldn't be doing.
Inclusion cyst, I think.
See if this plays now.
So I think we'll do a little bit of a histo sample for that. So we've got a pot, guys. We've got a pot. We're just going to send this off. Let's see if we get a little bit more. So I was thinking differential was inclusion cyst. Hold there, Karen. I'm going to get another picker. See if I get a bit more. Oh, okay. So I was hoping to get it all out in one. So inclusion cyst it is. Is that light still playing silly buggers? Sorry. Try that. So that makes it an inclusion cyst. We'll get all of that out. Right, we'll clean it up. Cheers, cheers, cheers.
Play. Some play.
Right, some plays it. Yeah. So that's it there. So we need to kind of get, goes down a ways. You see, it's quite lobulated. You see from the MRI.
That distal bit is where I popped that first sac.
So we're just gonna, it's quite irregular. No swearing. U's not a swear word. And there's the size of it, so you can really see you've got, you really see you've got this epithelial lining, and that's, we'll have more in there, but that's quite firm. That was where there was the first sac that was popped. Alrighty, it's a girl.
So that's just another view in between those two little short videos of taking it all out and having gone in and popped the first sac, which I was a bit disappointed at, but that happens. I was expecting really more of an adventitious bursa, or perhaps even a ganglion, although obviously inclusion cyst was there in the differential, as you'll see from the MRI report. So that all came out, and then we had a couple sample to send off, a couple of pictures of the samples. And if you look, let's have a little look. That's on the underside of the lesion. There's my mouse. So that's where I'd popped the distal end. That's that distal lobule. That's the outside, and the little hole on the left is the underside. And then you've got the kind of the second main lobule, which I decided not to pop. It would have been the same cheesy keratinous product, but it obviously goes off to histology. So having cleaned it all out, then I've gone back in, taken out any stray tissue that looks a little bit irregular. You can see you've got the underside now of the first metatarsal phalangeal joint. There's still kind of a healthy amount of sub-Q fibrofatty padding there, but anything that was suspicious for the cyst would come out. But I'm pretty happy that I've got the epithelial wall of that inclusion cyst, and then irrigate the bejesus out of it, because we want that to close nicely and not be an inflamed wound. beautiful stitching. I'm always amazed how many people say, oh, look at that Cornish pasting. That, of course, is how you should suture. I could talk about that at length, and perhaps I will, when I get 5 minutes, do a little series on how to suture, because I've got some views on that. And as I say, it absolutely goes off to histo. Common things occur commonly. I really like the phrase, if you hear the sound of distant hooves, it's probably a horse. It's not likely to be a zebra. But occasionally you will get them to come back and they are zebras. I get perhaps 1, maybe 2 a year that come back, and they're a bit cheeky, shall we say. But the way to avoid that is good history taking. You'll have an idea of what the lesion is prior to history, and imaging. And if in doubt, refer on. So I use my sarcoma service once, twice a year if I've got any doubt at all about a lesion based on rapidly growing or size or other issues in the history. What you really don't want to do is take a lesion out, find out on the histopathology report 10 days later that it was malignant, and then you've got to go back in to a wound that's healing and do a wider excision based on the particular flavour and personality of the lesion. It's not considered sporting. Righty, last slide then. So this was just a little case study that I found. There are other ones online, and if you find that, you'll find some nice references at the end. But it's a not uncommon lesion, certainly body-wise. They're really quite common, as you'll see from that first reference. In terms of plantar lesions, they're not coming off the hair because there ain't no hair on the plantar aspect of the foot. So epidermal inclusion cyst, and I'm living in the UK. It's currently pissing down a rain, cold, wet and miser, and you're not going to be walking around barefoot. But if I was living in an area where walking barefoot was more the norm, then we'd be seeing more penetrating injuries on the plantar surface of the foot, and I fully suspect more epidermal inclusion cysts and retained foreign bodies for that matter. Righty guys, thanks for watching. Sorry it was only a short video and it's a bit wibbly wobbly, but the best laid plans of mice and men, hey.